This conference will now be recorded.
Good morning. Am I audible to you?
Yes, ma'am.
Okay. So today our session is on how do you approach to a case of respiratory distress. So what are all the, first we will see what is increased work of breathing or what is respiratory distress, presence of any tachypnea or presence of chest retractions like subcostal, intercostal or suprasternal retractions. First is the increased rate of breathing. Second one is the increased workload on breathing, and adventitious sounds like any stridor present, any wheeze or any grunt, flaring of alar nasi, head bobbing, and abdominal breathing. All these are the signs of increased work of breathing. Head bobbing and abdominal breathing indicates the severity of the respiratory distress. If head bobbing is present, you might take it like the child is going on for ventilator. So relationship of compliance, resistance and elasticity to the respiratory rate. If there is a good compliance or the good compliant lung, see at the level of like 600, it is good compliant lung, the respiratory rate frequency will be quite low. So there will be good elasticity and low resistance. So respiratory rate will be low. Coming to the pulmonary causes of respiratory distress in a child, you will divide it broadly into airway obstruction causes, parenchymal diseases and pleural diseases. Airway obstruction, extrathoracic, intrathoracic and parenchymal disease and pleural diseases. So extrathoracic forms, extrapulmonary and intrapulmonary, we will see the examples now. Extrathoracic is like the upper airway part. So upper airway, what will be the causes? You already know croup is the one of the most important cause, but in croup also, croup syndrome also, epiglottitis is the upper airway most commonly affected. Acute laryngotracheobronchitis, epiglottitis, retropharyngeal abscess and any diphtheria. These are the 4 causes of upper airway obstruction which we commonly see. And coming to the intrathoracic part, that is the lower airway part, we have an extrapulmonary and intrapulmonary both. Extrapulmonary examples are vascular ring and mediastinal masses. Intrapulmonary are bronchiolitis and asthma. In extrapulmonary, we can see foreign body aspirations also. But in intrapulmonary, mostly the wheezing causes like bronchiolitis and asthma. Parenchymal diseases, pneumonia, and pleural diseases are pneumothorax and empyemas. So coming to the stepwise approach, how do you approach to a case of respiratory distress stepwise? First of all, look at whether it is a respiratory disease or not. If so, if it is not respiratory, what is the other cause? So what is the anatomical level which is involved? What are all the useful investigations you want to go, and are there any features of respiratory failure? So what are the normal respiratory rate and heart rate? Non-respiratory causes of respiratory distress are usually serious causes and metabolic causes. So first we will see the normal respiratory rate and heart rate according to the age. In a newborn, it is 30 to 40 respiratory rate, 1 year 25, 10 year 20, adult it is 18. And heart rate newborn 120 to 160 is normal, for 1 year 100 is normal, 10-year-old child 80 is normal and adult is 72. These are the normal heart rates and respiratory rates in a child. So tachypnea in different groups, age and breaths per minute. This you remember like 60, 50 and 40. Here it is 2 months, 2 to 1 year and more than 1 to 5 years. 60, 50, 40, 60 or more. If it is less than 2 months, rate more than 60, you call it as respiratory distress. 50 or more, 2 months to 12 years, you call it as respiratory distress, and 40 or more, 1 year to 5 years. Non-respiratory conditions which mimic respiratory emergencies are cardiac failures, shock, acute GE with dehydrations, metabolic acidosis like DK and RTA, salicylate poisonings, and acute encephalitis. All these conditions also in acute encephalitis, if there is rise to ICT, you can see if it leads to Cushing triad, you can see hyperventilations and all those poisonings, metabolic decay, Kussmaul breathing, acute GV dehydration. When it goes to Kussmaul breathing, you can see the abnormal respiratory pattern, shock also, respiratory distress, work of breathing will be more, and cardiac failures of the cardiogenic shock or cardiac symptom or cardiac diseases causing respiratory distress are seen. So how will you differentiate between acidotic breathing and a respiratory distress? So respiratory rate in acidotic breathing is much more higher. The rate will be much more higher in acidotic breathing when compared to a respiratory distress, but retractions will not be there. Only silent tachypnea. It is like almost like silent tachypnea. Retractions are not there, but retractions are more common in a respiratory distress. CVS will be normal in acidotic breathing and abnormal in respiratory distress cases. Respiratory system, when you hear to respiratory system, it will be normal and abnormal in a case of respiratory distress. And chest x-ray, hyperventilation might be seen in acidotic breathing, but in respiratory distress, you can see a picture of consolidation or presence of any cardiomegaly or empyemas. So approach to a child with increased respiratory rate. Coming to the respiratory, cardiac and metabolic causes, tachypnea, you can see in all of them. If it is a respiratory cause or cardiac cause or metabolic cause, tachypnea is common, but retractions are seen in respiratory. Most commonly, marked retractions are seen in respiratory causes and minimal retractions in cardiac and metabolic. Already we have discussed metabolic acidotic type of breathing, retractions will be absent. Coming to the respiratory noises, snoring, stridor, wheeze and grunt, and phases of respiration and localization. Snoring, on the phases of respiration, see whether that is inspiratory or expiratory snoring. Localization is at the level of oropharynx. Usually the localized site is oropharynx. Stridor, usually it is an inspiratory finding and wheeze is an expiratory. So stridor inspiratory finding, localization is in the larynx, and wheeze expiration, small airways. Grunt expiration because of the alveoli. The sound is produced from the alveoli part. So interpretation of signs, airway obstruction, parenchymal and pleural. Already we have discussed the causes in the previous slides. In the airway obstruction also, first I will tell about airway obstruction, upper and lower difference. In airway obstruction, coming to the upper airway and lower airway, tachypnea is in both of them. Chest indrawing is also seen in both of the airway obstructions. But stridor is more common in upper airway because it is an inspiratory and the localization is also at the level of in the previous slide, we have seen the larynx. So at the level of larynx, airway obstruction occurs and it is an inspiratory cause. Wheeze at the smaller airways, so it is usually lower. Grunting is absent in airway obstruction. Coming to the parenchymal diseases and pleural diseases, tachypnea is present in both of them, and chest indrawing is much more severe in parenchymal than the pleural diseases. Stridor is absent in both of them. Wheeze if we have a parenchymal disease, and absent in pleural disease. Grunting is seen in both of them. So if a grunt is present, you can think it is a parenchymal or a pleural disease and you rule out the airway obstruction. If it is between a parenchymal and a pleural disease, the absence of wheeze, if it is parenchymal, wheeze will be present and chest indrawing will be more in parenchymal when compared to pleural disease. That is the difference. So description of respiration, we describe it according to the rate, rhythm, depth and ease of breathing. So these are the rates I am just showing you for interpretation. When you see eupnea, you have a fixed respiratory rate with fixed intervals, eupnea. Tachypnea, increased work of breathing, increased respiratory rate, and see if the eupnea is 20 per minute is normal, here it is 60 per minute, and bradypnea it will be decreased, so it is only 12 per minute. These are all taken in a period of 0 seconds to 15 seconds. So rhythm of respiration, now describing the rhythm. That is the normal, first one is the normal rhythm of respiration. When you have a periodic breathing, you see a apnea between the normal rhythm, but apnea is less than 10 seconds. So apneic spells are apnea for more than 20 seconds, you call them as apneic spells. If periodic breathing, the period will be less than 10 seconds, and the apneic spells, the period is more than 20 seconds. Chinese talk breathing, crescendo and decrescendo patterns of periods, patterns with periods of apnea in between. You see the rhythm, it will be crescendo, and again at the peak in between, the crescendo pattern with periods of apnea in between. And Biot's breathing, you can see the varying depth and rate also with periods of apnea. See the first spike, it is a little bit low, depth is varied for the first and the second wave, and even with the rate is also disturbed, like there are periods of apnea in between. Depth of respiration, this is the normal depth of respiration. Slow and deep is the depth is increased, and rapid and shallow the depth will be decreased. So evaluation of a respiratory distress, coming to the respiratory pattern, rapid and shallow and grunt is present. I have already told you grunt present, rule out the airway obstruction, go for a parenchymal or a pleural. Rapid prolonged inspiration with stridor. So stridor is an upper airway. Think about Krupp syndromes. Rapid prolonged expiration with wheeze. Wheeze is a smaller airway diseases. Think about asthma. Increased respiratory rate and depth, non-respiratory metabolic acidosis. Silent tachypnea, which I have told earlier. So evaluation of respiratory diseases, evaluation of respiratory distress, respiratory pattern, and coming to the diseases. Respiratory pattern, if it is a paradoxical breathing, think about CCF. Tachypnea with minimal intercostal retractions with tachycardia, think about diaphragmatic paralysis. Irregular rate, depth, and rhythm, Biot's breathing, and brainstem injuries, and slow, shallow or drowsiness, barbiturate poisoning. Think about if drowsiness is there, go for a poisoning. Biot's breathing is irregular rate, depth, and rhythm, all of them. Rate, depth, and rhythm, 3 of them are gone. Biot's breathing, brainstem injuries, and tachypnea with retractions and tachycardia, diaphragmatic paralysis, and paradoxical breathing in CCF. Choice of investigations, you want to take a chest X-ray first to rule out whether it is a respiratory or a CVS cause. Take a CBP to rule out any infections. Take a CRP to rule out infection. Blood culture, culture of the sputum, you will take a sputum culture, nasopharyngeal secretions, and or tracheal aspiration. Assessment of hypoxia, pulse oximetry, or by ABG. You can take by both of them. What are the additional investigations you want to go with a respiratory distress? X-ray neck lateral, this is for foreign body rule out or upper airway obstruction. Barium swallow to rule out tracheal compression. CT chest to rule out extraluminal causes. And bronchoscopy, flexible fiber bronchoscopy to rule out any intraluminal obstructions. Echo to rule out cardiac conditions, and ultrasound chest to rule out any pleural fluid. So just I'm showing you pictures of X-rays. So this is an X-ray of a child. So first you will see whether there is a trachea is in position or not. First see what is the view of the X-ray. Usually in pediatrics, this X-ray is taken in the child's sleeping position. So most commonly it will be in an AP view. And I'm not describing the total X-ray. See the trachea is in midline, and this is how you count the spaces. 1, 2, 3, 4, 5, 6, 7, 8 spaces are there. So the cardiac position is normal. You take a CT angle and see whether its cardiac thoracic ratio is good or not. If it is increased more than 60%, it is abnormal. take a cut and see for any markings in the lung like consolidation. This is how you want to take a X-ray. So this is one of the X-ray. See the trachea slightly towards right side, AP view, and spaces 1, 2, 3, 4, 5, 6, 7, 8. 6 to 8 spaces are normal. Left side mild, it is increased more than 8 and a half in left side. So this is also X-ray. Somewhat hyperinflation is seen on the left side. So the mediastinum is slightly shifted towards the right side. So can anyone tell what is this? Presence of hypointense areas. See the mediastinum here. You can't see the trachea here. You can't see the mediastinum. Mediastinum is shifted totally towards the left side. And what might be the cause in right side? Shifting the mediastinum, pushing the mediastinum to the left side. It is right-sided pneumothorax. So this is an example of consolidation of X-ray. Maybe might be pneumonia. Midlobe consolidation is present. Most probably pneumonia. See, this is a neonate AP view showing totally white out lungs in the left side. And right side also up to 1/3 of the chest is white out. So increased respiratory work. See whether the child is in respiratory failure. First go non-respiratory causes like shock. There will be increased respiratory work leading to fatigue and lung failures like interstitial diseases and alveolar disease. The gaseous exchange is lost and hypoxemia, failure of hypoxemia. Again, fatigue also leads to failure of hypoxemia, and this gaseous exchange or failure of hypoxemia leads to increased respiratory rate, and they may go for ventilatory failure or hypercapnias. And in the pump failure, central and peripheral, ventilatory failures and hypercapnias are common. This is almost like a vicious cycle. Assessment of respiratory dysfunction. Clinically, how do you assess? By the hypoxia. When the child is hypoxia, the child will be irritable, agitated, and mental confusion will be there. Drowsiness is present and hypotonia is present. Hypercarbia, generalized vasodilatation or flushings are seen. Muscle fatigue, seesaw type of respirations are common. Biochemical parameters, PaO2 less than 60 mm of Hg, PCO2 greater than 50 mm of Hg, and pH less than 3 might be the biochemical parameters. These are, you take the baseline levels. Normal PaO2 is between 60 to 80 mm of Hg. If it is less than 60, you can think of the oxygenation is poor, and normal CO2 will be 40 to 50 or 35 to 45 mm of Hg. More than 50, you take it as abnormal, and pH of normal is 7.35 to 7.45. Less than 7.3, you take it something abnormal. So how do you interpret a EBG? See, there are mostly respiratory distress, respiratory acidosis, and alkalosis. I am concentrating in this slide. In the respiratory acidosis, what will happen? Acidosis means the pH will be absolutely low. See the pH value in the respiratory acidosis. In the third one, respiratory acidosis, pH will be low and carbon dioxide will be more than oxygen. So PCO2 will be increased and PO2 will be decreased. Oxygenation is low, but CO2 levels are increased. So CO2 levels are increased and PO2 is decreased, and bicarbonate is normal or decreased. Bicarbonate usually normal, because that is a metabolic, bicarbonate represents a metabolic form. So coming to the respiratory alkalosis, the pH is increased in alkalosis. So when alkalosis is there, the PO2 will be normal, but PCO2 levels will be low. In acidosis, PCO2 levels will be high and bicarbonates are normal. In a transition, between a transition form, the pH is normal, PCO2 is low, PO2 is low, and bicarbs are also low. And combined acidosis, if it is both metabolic and respiratory acidosis, acidosis itself shows pH is low, and combined is there, so PO2 is low, PCO2 is increased, and metabolic is also combined, so bicarb also will be low. So coming to the respiratory distress ABG, respiratory distress without respiratory disease inside, that is hyperventilation like CNS stimulations or metabolic diseases. In CNS stimulation, the PCO2 will be normal, pH will be low, and PO2 increased, and metabolic normal, decreased and decreased. Severe respiratory failure without obvious respiratory signs, that is hyperventilation, CNS depression or neuromuscular, PCO2 decreased and pH is increased and PO2 is decreased. So respiratory distress, when to refer? When the child, if any of the following below signs are seen, that indicates it should be referred immediately. Inability of the child to drink or speak. So inability to drink, severe dyspnea, severe respiratory distress is there. Air entry is not, the diminished air entry when you auscultate, presence of stridor even if the child is sitting normally, audible wheeze for you, any expiratory grunt audible for you, presence of visible cyanosis, apnea is present, or gasping. The child is in gasping, he goes for the ventilation. So conclusions are respiratory distress is not a disease, it is a symptom or a sign. A good history and thorough physical examination gives good clue to the diagnosis. Respiratory rate, increased intercostal chest retractions, and respiratory noises pinpoint the diagnosis. I have already told you when to differentiate between a stridor, wheeze, and a grunt. X-ray chest confirms almost. ABG will specify or quantify how much the distress is and how to intervene. Decreased respiratory rate is an obvious sign. Early identification, see, bradypnea is much more dangerous. Early identification and prompt treatment is usually associated with good outcomes. And respiratory rate is the simplest pulmonary function test which we practice daily. RR gives you most of the things, respiratory rate. Thank you. Please save your chat. Everyone save your chat.